Hello, my name is Mark Rabat. I'm a professor of medicine and radiology and the director of cardiac imaging, as well as a program director of Advanced Cardiac Imaging Fellowship at Loyola University in Chicago, and the immediate past chair of our advocacy committee of the Society of Cardiovascular CT. Today, I would like to present three different cases on utilizing CCTA and Heartflow's AI to inform coronary artery disease diagnosis and management. Case number one is a 73-year-old neuroradiologist with hypertension, dyslipidemia, family history of coronary artery disease who presented for initial consultation. He was endorsing fatigue but attributed this to his age. He's a very active gentleman who's competed in multiple senior Olympics and won various gold medals in swimming. He had a prior nuclear stress test a few months ago, which was negative. There were no perfusion abnormalities and no EKG changes. He was on rosuvastatin 40, ezetimibe 10, and aspirin 81. His LDL was 73, and triglycerides were 85. After discussion with the patient, we decided to proceed with a coronary CT angiogram. This is the patient's roadmap analysis. Roadmap rapidly visualizes and assesses disease severity via these color-coded capsules. You can see on this patient's roadmap that he was found to have multivessel coronary artery disease, with 30 to 49% stenosis in the RCA as well as a circumflex artery, and serial lesions in the left anterior descending artery in the 50 to 69% diameter stenosis and the 70 to 99% diameter stenosis. This is the patient's coronary CT angiogram focusing on the left anterior descending artery, again demonstrating the mixed calcified and non-calcified lesions in the left anterior descending artery in the 50 to 69% and 70 to 99% diameter stenosis. Now, in order to assess whether these lesions were hemodynamically significant, I had ordered an FFR-CT analysis. This is the patient's color-coded FFR-CT map that was computed and analyzed. And what you can see here is that the lesions in the RCA and circumflex were not hemodynamically significant, but in the LAD, you can appreciate the large delta gradient of FFR across that left anterior descending lesion, with a lesion-specific FFR-CT value of 0.65. After discussion with the patient and shared decision-making, we decided to proceed with an invasive coronary angiogram and percutaneous intervention of the left anterior descending artery. On the left image, you can appreciate the invasive coronary angiogram that corroborated the CT angiogram findings. And on the right, you'll appreciate the post-PCI result with resolution of the patient's symptoms. He underwent successful percutaneous intervention and is now feeling better. Now, in order to further characterize his residual risk, I ordered an AI quantitative coronary plaque analysis. This is the patient's AI quantitative coronary plaque analysis with his patient-specific percentiles. So his total plaque volume was extensive at 996 millimeters cubed, 85% of which was non-calcified in nature. And you can see on this slide that he had plaque in all of the major epicardial vessels, with 93 millimeters cubed in the left main, 391 millimeters cubed in the LAD, 45 millimeters cubed in the circumflex, and 467 millimeters cubed in the RCA. Now, based off of his age and sex, you can see that he fell in the 74th percentile for non-calcified plaque at 842 millimeters cubed. Now I would like to share the latest data on plaque volume staging. Multiple approaches to risk stratify patients were evaluated by cardiologists and CT experts to align on Heartflow's plaque staging. Now, plaque staging stratifies patients based on their total plaque volume, which is a strong predictor of myocardial infarction, irrespective of cardiovascular risk scores, coronary artery calcium scores, or stenosis. So mild is in the 1 to 100 range, moderate in the 101 to 250 range, severe in the 251 to 750 range, and extensive being greater than 750. Now, this may be a nice starting point as you think about your patient's decisions. Real world impact on this medical management is being studied in the DECIDE registry, which is the largest prospective registry of its kind with a target of approximately 20,000 patients. Now, based on this rubric, medical management was intensified for this patient with the addition of a PCSK9 inhibitor to target an LDL as low as can be achieved. Thank you for listening.